next presenter is Dr. Park, who's going to present on robotic gastric bypass, and they're proposing that it's a future of bariatric surgery from University of Hawaii. Dr. Park.
Thank you, Dr. Anvari, Dr. Lee, for this opportunity to speak to you today. Aloha, ladies and gentlemen. Thank you for this opportunity. My name is Chan Park, and I'm going to be talking to you about robotic-assisted gastric bypass performed in our community hospital setting. And we'll hopefully try and answer some of these questions about whether or not it is indeed a future of gastric bypass surgery. I have no disclosures to disclose. With that, let's begin. Americans today are facing a huge epidemic problem. Nearly 2/3 of us are considered to be overweight, and according to the CDC, about 1/3 of us are actual potential candidates for bariatric surgery. In the United States, in 2008, approximately 220,000 bariatric procedures were performed. Contrast that with robotic surgery, and although it's enjoyed a lot of wide applications in a number of different fields, including gynecologic surgery, oncologic surgery, urologic surgery, as well as general surgery, application in terms of bariatric surgery has been quite limited. And experiences with this type of technology has really only been from larger academic centers, and community hospital setting experience has been quite unestablished at this point. This is all despite the reported benefits of enhanced optics, better surgical mobility, which one would hope translate into a better surgical precision. But we wanted to ask the question, does this really mean anything? Does this directly translate into patient outcomes and benefits? So that's the reason for our study. We looked at our experience, our local experience between 2007 to 2009. Just as an aside, our hospital, Queens Medical Center, and our comprehensive weight management program, this is based at a 560-bed community type of hospital affiliated with the University of Hawaii. And in our study period, we performed over 300 bariatric procedures. And for the study groups, there were approximately 105 in the robotic arm and about 195 patients in the laparoscopic group. And if you look at these groups and compare them, there really was no difference in terms of age, gender distribution, in terms of ethnicity profiles. Now, just going to take us a moment here to explain, although this ethnicity distribution may look a little bit different from what you would normally expect in a mainland institution, let's say someplace around here in Washington, D.C., or maybe even in Canada, I can assure you that this reflects the local population in Hawaii, with the majority of our patients being of Asian and Pacific Islander descent. But really, there was no difference, and also in terms of BMI or comorbidity incidence and prevalence, there really was no difference between the two groups. And so what did we find? Right off the bat, I can tell you the only statistically significant difference that we were able to identify was that there was indeed a statistically significant difference in operative time, and the mean difference was about 17 minutes in total time. Now, when we looked at this a little bit more in depth, we also noted that our early experience compared to our more recent experience with robotic surgery, there's been a steady downward trend in our operative times. And so we think that this holds a tremendous amount of potential for the future. Continuing on our discussion, in terms of estimated blood loss, percentage of excess weight loss, as well as hospital lengths of stay, there was really no difference that we could identify between the two groups. And in terms of complications, they were almost identical, 9.5 to 9.7%. And there's also the breakdown there of the various types of complications that we saw. And lastly, in terms of conversions, while there were 3 conversions to open surgery in our laparoscopic group, there were absolutely no conversions in our robotic group to an open procedure. There was one patient who had to undergo conversion to a laparoscopic procedure, and that was mainly attributable to body habitus. The patient was a BMI of over 50, a super obese patient on whom we just could not dock the robot properly just because of the size of her abdominal girth. So in conclusion, I think that the robotic gastric bypass in a community setting is a safe procedure, and it is efficacious. Now, I think that the word that we have to focus on is that this is a non-inferior mode of treating obesity. As you can see from all of our data, complications, estimated blood loss, weight loss, length of stay, there was really no difference. Now, the final thing I'd like to point out, cost has been always brought up as a possible barrier to application of robotic technology in both academic and community centers. But when we looked at our data, we looked at the hospital charges per patient compared between the robotic and the laparoscopic group. We found that there was also, again, a near equivalence. I'm unable to provide you with the actual dollar amounts due to proprietary reasons and our hospital policies, but I can assure you that there really was no difference in cost. The only difference, as I pointed out earlier, was that there was a difference in operative time, but the decreasing trend, I think, holds a lot of promise in the future, and we're hoping that with future prospective trials, we can further study this effect. And lastly, the exposure that surgical residents, such as myself, have had to robotic surgery has been a direct result of this type of a program. And as a matter of fact, the University of Hawaii residency program has been able to develop a surgical resident training program that allows the resident to be exposed to robotic technology, which I believe up to this point has really been unpublished and unstudied at this time. So with that, I'd like to say mahalo nui loa, which means thank you very much, and I welcome any comments or questions. Thank you.
Thank you very much. Questions?